Don't let acute neck pain be a pain in the neck. A 45-year-old woman with no previous medical history presents to the emergency department with neck pain, left-sided headache, and 10 minutes of transient right-sided weakness that occurred after she fell off a stool in her kitchen 2 hours ago. Neurological examination shows mild ptosis and meiosis of the left eye. There is no lacrimation or rhinorrhea. Fundoscopic examination is normal. No carotid bruit is present. She has normal strength, deep tendon reflexes, and sensation in the upper and lower extremities. What is the most likely cause of this patient's current condition? The etiologies for acute neck pain are broad. Differential diagnoses include neurologic, such as Arnold-Chiari, vascular and inflammatory causes, musculoskeletal, like compression from osteoarthritis. Infectious and neoplastic causes should also be considered. Taking a detailed history and performing a thorough physical exam will help narrow down the differential diagnosis. Numerous causes of cervical neck pain may present with neurological symptoms, including carotid artery dissection, cervical radiculopathy, or myelopathy, and demyelinating diseases. Carotid dissection produces neck pain and headache on the side of the dissection and may lead to stroke symptoms or a partial Horner syndrome consisting of ptosis and meiosis without anhidrosis. Evaluate the patient for unilateral symptoms in the head, neck, and face, such as weakness and paresthesia. Cervical radiculopathy presents with neck pain, paresthesia, and sometimes weakness in the arm. Cervical myelopathy may cause neck pain, weakness, increased tone, and reflexes in the upper and lower extremities, and gait abnormalities. Both problems can be assessed with nerve conduction studies and electromyography along with cervical spine imaging. Multiple sclerosis may cause neck pain and Lermite sign, which is a sharp pain or electrical sensation that radiates down the spine and sometimes out into the limbs during neck flexion. Musculoskeletal conditions are some of the most common causes of neck pain. A history of recent or chronic neck trauma and occupational habits that produce tension in the neck and shoulder muscles suggest a musculoskeletal etiology. Pain is usually exacerbated with palpation and is often well localized. Patients commonly experience stiffness or decreased range of motion in the neck. Infectious causes are important to quickly identify. History should include inquiry about recent exposure to possible infectious sources. Patients often have a fever and may be encephalopathic. Be sure to examine the lymph nodes, skin, and assess for neck rigidity during flexion movements. Neoplasms can also present with acute neck pain, and it is important to ask about constitutional symptoms such as unexplained weight loss, fatigue, or night sweats. Risk factors such as smoking or family history of cancer, and if they are up to date with recommended cancer screening. Examination should include the lymph nodes. Assess for voice changes and ask about shortness of breath, as neoplasms can compress the trachea and the recurrent laryngeal nerve. The most likely diagnosis in our patient is a carotid artery dissection, which can occur spontaneously or after trauma, and may cause a stroke or transient ischemic attack. Her exam findings are consistent with partial Horner syndrome. The diagnosis of dissection may be confirmed with CT or MR angiography. Treatment in this case consists of antithrombotic therapy, either antiplatelet or anticoagulation. For more information on evaluation of acute neck pain, including a more detailed differential with red flags, please see the course resources. For more information on this and other neurological conditions, please visit aan.com/NeuroBytes.